Today, we will be going over the Dissociative Neurological Symptom disorder in the ICD-11, which is supposedly, quote unquote, supposedly, more reputable than the DSM-5 text revision. So, given that, I figured it would be very, we'll say, very helpful to go over what it is we find in this document, this online website. So let me take a drink of my juice.
A Coca-Cola glass.
Let's get into this.
Description.
So, the description of dissociative neurological symptom disorder is characterized by the presentation of motor, sensory, or cognitive symptoms that imply an involuntary discontinuity in the normal integration of motor, sensory, or cognitive functions and are not consistent with a recognized disease of the nervous system, other mental or behavioral disorder, or other medical condition. The symptoms do not occur exclusively during another dissociative disorder and are not due to the effects of a substance or medication on the central nervous system, including withdrawal effects or sleep-wake disorder.
Exclusion.
Also, with the exclusion of acute stress reaction, which I will say, quote unquote, this is straight from the website. Acute stress reaction refers to the development of transient emotional, somatic, cognitive, or behavioral symptoms as a result of exposure to an event or situation, either short or long-lasting, an extremely threatening or horrific nature, example, natural or human-made disasters, combat, serious accidents, sexual violence, assault. Symptoms may include autonomic, possibly one or two, autonomic, signs of anxiety. Example, tachycardia, sweating, flushing, being in a daze, confusion, sadness, anxiety, anger, despair, overactivity, inactivity, social withdrawal, or stupor. The response to the stressor is considered to be normal given the severity of the stressor and usually begins to subside within a few days after the event or following removal from the threatening situation. So basically, acute stress reaction could be a possible minor form of PTSD, a form of trauma, basically. I think it's saying without the inclusion of trauma, I believe.
Exclusion.
But also with the exclusion of uncomplicated bereavement, normal grief, and bereavement NOS.
Exclusion.
And the final exclusion of factitious disorders. Factitious disorders are characterized by intentionally feigning, falsifying, inducing, or aggravating medical, psychological, or behavioral signs and symptoms or injury in oneself or in another person, most commonly a child dependent, associated with identified deception. A pre-existing disorder or disease may be present, but the individual intentionally aggravates existing symptoms or falsifies or induces additional symptoms. Individuals with factitious disorder seek treatment or otherwise present themselves or another person as ill, injured, or impaired based on the feigned, falsified, or self-induced signs, symptoms, or injuries. The deceptive behavior is not solely motivated by obvious external rewards or incentives. Example, obtaining disability payments or evading criminal prosecution. This is in contrast to malingering, in which obvious external rewards or incentives motivate the behavior. The essential features of dissociative neurological symptom disorder include bullet point 1, involuntary disruption or discontinuity in the normal integration of motor, sensory, or cognitive functions lasting at least several hours. Clinical, bullet point 2, I may add, clinical findings are not consistent with a recognized disease of the nervous system, example, a stroke, or another medical condition, example, a head injury. Bullet point 3, the symptoms do not occur exclusively during episodes of trance disorder, possession trance disorder, dissociative identity disorder, or partial dissociative identity disorder. Bullet point 4, the symptoms are not due to the effect of a substance or medication on the central nervous system, including the withdrawal effects. Do not occur exclusively during hypnagogic. I will add the, description of what it is I'm saying. Hypnagogic, or hypnopompic states, and are not due to a sleep-wake disorder. Example, sleep-related rhythmic movement disorder, recurrent isolated sleep paralysis. Bullet point 5. The symptoms are not better accounted for by another mental disorder. Example, schizophrenia or other primary psychotic disorder, post-traumatic stress disorder. Oh, so I had it all wrong. Of course, I'm reading it with you guys. So I'm relaying the information. So I guess this will add to the knowledge of, no, it does not add to it. No. It is not a form of post-traumatic stress disorder or a minor traumatic episode of something that has happened. Which is odd. I would probably have to do a little more research on how, because I don't understand how you can experience this dissociative disorder without that included, but I guess it's its own disorder, relative, or irrelative to this. I would need to do a little more research. And then bullet point 6. The symptoms result in significant impairment in personal, family, social, educational, occupational, or other important areas of function.
Not to allow the IT community to become infected with the sort of self-defeating scientism.
Symptom specifiers. Specific presenting symptoms in dissociative neurological symptom disorder may be identified by using the following symptom specifiers. Multiple specifiers may be assigned as necessary to describe the clinical presentation. And that'll be with visual disturbance, characterized by visual symptoms such as blindness, tunnel vision, diplopia, visual distortions or hallucinations that are not consistent with a recognized disease of the nervous system, other mental disorder, or another medical condition, and do not occur exclusively during another dissociative disorder. And the next one is with auditory disturbance, characterized by auditory symptoms such as loss of hearing or auditory hallucinations that are not consistent with a recognized disease of the nervous system, other mental disorder, or another medical condition, and do not occur exclusively during another dissociative disorder. And so on. There are a couple more. I'll list them right here, and you can check it out. I am just going through it. The next chapter in this disorder is boundary with normality, parentheses, threshold. And it says, the first bullet point, 2 out of 2 bullet points, transient alterations in sensory or cognitive functions that can accompany intense engagement in work or sports or intense emotional states, and transient difficulties in coordinating movements, example, during situations of intense anxiety, are relatively common and do not result in significant impairment in personal, family, social, educational, occupational, or other important areas of functioning. Such transient experiences should not be considered as symptomatic of dissociative neurological symptom disorder. Going through it literally. Now, the second bullet point of boundary with normality is experiences resembling dissociative neurological symptom disorder can occur as a part of culturally sanctioned rituals and in some cases can persist for several months, example following a death. If such presentations are not associated with impairment in functioning, a diagnosis of dissociative neurological symptom disorder should not be assigned. Depending on the nature of the circumstances preceding the onset of symptoms, as well as their duration, acute stress reaction may be considered.
Now's our chance. Fire!
Course features. Onset of dissociative neurological symptom disorder typically occurs between puberty and early adulthood, although onset in early childhood as young as the age of 3 has been observed and is extremely rare. It is extremely rare. It says, quote, like if I were to really be, factual, it says it is extremely rare, but I just, onset after age 35 is uncommon. And the second bullet point says the onset of dissociative neurological symptom disorder is usually acute, and the disorder may follow either a transient or a persistent course. Symptoms are typically of brief duration, example, remission within 2 weeks, but commonly recur. Bullet point 3. Onset is often associated with a traumatic or adverse life event, which is kind of weird because I'm already at a confusion with the PTSD, how you hold it. Pause. Prior physical injury and a history of childhood abuse or neglect are risk factors for dissociative neurological symptom disorder. In addition, a prior disease of the nervous system is a risk factor for the disorder. For example, individuals with a history of epilepsy are more likely to exhibit non-epileptic seizures. Patients may also present with symptoms that closely resemble the symptoms of physical illnesses experienced by their friends or family members. Bullet point 4. Non-epileptic seizures are more likely to have their onset earlier in the lifespan than motor symptoms. Bullet point 5. Positive prognostic factors include younger age, acute onset associated with a clearly identifiable stressor, early diagnosis, monosymptomatic presentation, short duration of symptoms, and short interval between symptom onset and initiation of treatment. Patients with a good pre-morbid adjustment, above average intelligence, and those who accept the psychological nature of the disorder also have a better prognosis. Negative prognostic factors include non-transient symptoms, polysymptomatic presentation, the presence of comorbid medical conditions, and co-occurring mental disorders, example, mood disorders or anxiety or fear-related disorders. Patients with maladaptive personality traits, history of sexual abuse, or poor physical functioning prior to diagnosis also have a poorer prognosis. And bullet point 6, individuals with symptoms of paralysis, aphonia, blindness, or deafness tend to have a better prognosis than those with symptoms of tremor or non-epileptic seizures. The developmental presentations. Bullet point 1. Onset of dissociative neurological symptom disorder in childhood is often associated with minor illness or physical injury. Bullet point 2. Gait disturbances and non-epileptic seizures are most prominent and the most frequent symptoms of dissociative neurological symptom disorder in children and adolescents. The range and number of symptoms observed often expands with age and duration of the disorder. Bullet point 3. The most common psychosocial stressor associated with dissociative neurological symptom disorder in children include bullying or victimization, school-related stressors, family conflict or parental separation, and the death of a relative or friend. Bullet point 4. Individuals with dissociative neurological symptom disorder often grow up with families that are excessively preoccupied with illness. And Bullet point 5. Adolescents with dissociative neurological symptom disorder frequently have co-occurring mood disorders, anxiety or fear-related disorders, as well as other medical symptoms. Mood and or anxiety or fear-related disorders often persist even after remission of the symptoms of dissociative neurological symptom disorder. Among adolescents, dissociative neurological symptom disorder is more likely to be transient. Now, if you guys are anything like me, you get a kick out of what it is we're going to talk about right now. Culture-related features of dissociative neurological symptom disorder. So, the culture-related features. Symptoms, this is bullet point 1. Symptoms of dissociative neurological symptom disorder that are typical in one cultural context may be considered unusual in another, such as localized heat sensations, peppery feelings on the skin, and sensations of being touched or pushed. These symptoms may be connected to local expressions of distress that reference cultural explanations of etiology, Aetiology. Example, spiritual origins, or pathophysiology. Example, subtle energies. Alternatively, in some cultures, dissociative symptoms may be attributed to an undiagnosed physical illness, such as occurs in hypochondriasis. Hypocon, CHON, DRIASIS. Health anxiety disorder, which is what it is. What that's called. Response to reassurance may suggest hypochondriasis rather than a dissociative disorder. Dissociative seizures and convulsions tend to have higher prevalence in low and middle income countries, and communities. Variations in prevalence may reflect greater traumatic exposure, sanctions against verbal expressions of disagreement by persons with marginalized status, or cultures in which somatic expressions of distress are more common. Lower prevalence of dissociative symptoms may be related to negative cultural views of such out-of-control behavior. Now, in this day and age, we are in a spicy territory. Sex and or gender-related features. Dissociative neurological symptom disorder is 2 to 3 times more frequently diagnosed in females who also have a younger age of onset. Bullet point 2. In men, dissociative neurological symptom disorder is associated with a history of industrial, military, or occupational accident. In women, symptoms are more often linked to stress caused by family or interpersonal interactions.
Today we're going to be talking about signs to look for if your cat's depressed.
Don't mind me being mummified. I popped a huge pimple on my face, so if I bleed on you, don't record me. The final section of dissociative neurological symptom disorder is boundaries with other disorders and conditions. Differential diagnosis in parentheses. Boundary with dissociative amnesia. Dissociative amnesia involves memory deficits that are manifested as an inability to recall important autobiographical memories, typically of recent traumatic or stressful events. The memory deficits are inconsistent with ordinary forgetting and are not due to the direct effects of a substance or a disease of the nervous system. If cognitive symptoms are narrowly focused on autobiographical memory, dissociative amnesia is the more appropriate diagnosis. Cognitive symptoms presented in dissociative neurological symptom disorder involve other cognitive phenomena. Bullet point 2. Boundary with other dissociative disorders. Dissociative motor, sensory, or cognitive symptoms are commonly a part of the clinical presentation of trance disorder. possession trance disorder, dissociative identity disorder, or partial dissociative identity disorder. A separate diagnosis of dissociative neurological symptom disorder should not be assigned if the symptoms occur exclusively during symptomatic episodes of another dissociative disorder. Bullet point 3, boundary with factitious disorder or malingering. In dissociative neurological symptom disorder, despite the presented symptoms, example seizures, paralysis, not being consistent with neurological findings or other pathophysiology, the symptoms are not feigned, falsified, or intentionally induced as in factitious disorder or malingering. And bullet point 4, boundary with mental disorders, with other mental disorders. Somatic symptoms that are not consistent with an identified medical condition also occur in bodily distress disorder, and a variety of somatic symptoms may also occur in schizophrenia or other primary psychotic disorders, mood disorders, anxiety or fear-related disorders, obsessive, compulsive, or related disorders, and disorders specifically associated with stress. Dissociative neurological symptom disorder should not be diagnosed if the symptoms are accounted for by another mental disorder. And the final bullet point, boundary with diseases of the nervous system and other medical conditions classified elsewhere. The diagnosis of dissociative neurological symptom disorder requires a medical evaluation to rule out diseases of the nervous system and other medical conditions as the cause of the presenting motor, sensory, or cognitive symptoms. In dissociative neurological symptom disorder, clinical and laboratory findings are inconsistent with recognized symptoms of diseases of the nervous system or other medical conditions as indicated by an alternative examination method. Example, normal simultaneous electroencephalogram, EEG, during an apparent seizure or convulsion. And that is all that has to do in the ICD-11 of dissociative neurological symptom disorder. So if you want me to continue going over the dissociative section of the ICD-11, I will. Just let me know in the comments. And if you want to request me do anything else in the ICD-11, to go over anything else, I will. So let me know. It gets pretty extensive, so it's gonna be a project. But thank you for watching, and good day, good night to you.